Good afternoon, friends. This is the 21st video of the biological methods of fracture management, and this is module 11 in the continuing modules. This module will contain 3 lectures, one on extension casting of humerus by me, one on featherweight plasters by Dr. Arvind Divakar Jain, and the last one on ergonomics in clavicle fractures. The title of my talk is "Keep two ends of humerus in the same room and they will unite unless an orthopedic surgeon enters." Humerus does not like metal. It is extremely fashionable these days to internally fix all humeruses irrespective of at all levels, irrespective of age, sex and comorbidities, especially if the patient is about 10 years. Sometimes even in 5 to 7 years old children, a criminal punishment of K-wires is necessitated by the over enthusiastic therapist, all intent on treating the X-ray. Newer implants like Philos and newer techniques like anterior bridge plating or minimally invasive plate osteosynthesis are making their appearance purely for commercial interest. We must remember the very essential points. Humerus is a highly vascular bone close to the heart, and union is a rule rather than an exception. Bad results of non-operative management are the results of bad management methods. If you do not administer any treatment and just leave the arm loose, the humerus will get sticky in a few days. Humerus is a bone in close contact with vessels and nerves, and iatrogenic complications of internal fixation are far too many to be ignored. Metal, opening the bone, soft tissue manhandling, periosteal stripping come with their own bonus of scars, stiffness, delayed non-unions and occasional disastrous complications of exposed plate and infections. Humerus is a stubborn bone that hates metal, and a few good results notwithstanding, surgical management of humerus is often associated with a plethora of complications which can be avoided by proper non-surgical management. I have oft repeated an orthopedic rule: keep two ends of humerus in the same room and they will unite unless an orthopedic surgeon enters the room, and this I stand by. Plates, nails, tubular external fixators, Ender's nails, tense nails, locking nails, all these contraptions without exception only delay the union of fracture humerus, which otherwise would have united easily. The following examples show the results of metal and surgery in a simple closed fracture humerus, where the surgeon did dare to enter the room and it ended up as a punishment for the patient. You can see where the plates are lying and where the screws are lying, and how the patient has to suffer for months and years, how bone gets resorbed and the bulky plates and nails keep floating hither and thither. Even within a few days, Despite protection, the fracture fails. Someone has tried to salvage a failed fracture with another method, and that too has failed. And we can see multiple failures of nails and plates. You can see locking nails compressed, nails with plates, bent nails, broken plates and floating screws, refracture at the tip of the process, the tip of the plate, multiple fractures with the original fracture not uniting. The disasters are too many and break and wrench your heart. The X-rays may look comical or funny, but imagine the plight of the patient. He has undergone one surgery, he has undergone a second surgery, he is now undergoing a third surgery, all for a fracture which did not need anything except for a simple cast in the beginning. And there are numerous newer methods, all which leave the patient with stiff shoulder, stiff elbow, non-union. And of course, the funny part, after surgery, the patient is put in a U-cast for a period of 6 weeks, and finally the patient ends up like this, having been subject to the punishment of both a plate and a cast, ends up with a hypertrophic non-union. Nail and a cast with cerclage wire. These are all efforts of treating the X-ray. Fantastic look in one view, and then you take the opposite view. The plate is not even in the bone, the screws are not in the bone, loosening within days. And then of course some dramatic fixations like putting 2 screws, opening medially and laterally and wiring the two and ensuring that the bone doesn't heal. Perfectly simple fracture which would have healed. Just the simple cast has been subject to inhuman tortures on the patient, like a lab experiment, and there he is with multiple cerclages and a plate with results. These are the X-rays that are sent to me by various students or colleagues or contemporaries from all over the world after third surgery, fourth surgery, fifth surgery and sixth surgery. The important question is why? Because the first surgery itself was not needed. Only because the first surgery was done wrongly, multiple repeat surgeries resulting in more and more bizarre complications land into the patient's lap. The patient is miserable, the surgeon spends sleepless nights, and the threat of litigation looms high on the head like a Damocles sword. So, what is the moral of the story so far? Humerus hates metal, and thus the right way to treat humerus is not by the use of nails or plates or metal. What is the logic behind extension casting for the fracture shaft of humerus and fracture shaft of humerus? And what are the results of the same procedure will be the theme magic of this talk. From ancient times, humeral shaft fractures have been treated conservatively. Before 1940, no humerus was operated, it always used to unite. Ancient Egyptian tombs had mummies with splints applied to forearm with elbow in extension. And we have also found by radiographs of united fracture humerus cast with splint in extension. Even in current times, bone setters treat humerus shaft fractures by bamboo splints in extension and these fractures invariably unite with some complications in small number of cases which are not due to the position of immobilization, but because of tightening of the splint resulting in neurovascular compromise. Before commercialization of humerus fractures with indiscriminate nailing and plating, they were all invariably treated non-operatively. Watson-Jones textbook from the 1980s advises management in a U-sling, U-cast or a hanging cast. And in the 1980s textbook, which was a Bible of orthopedics at those times, there is no mention of plating. However, these methods are gradually replaced internal fixations because though conservatively treated humerus fractures united, they did so with some malalignment and shortening. Radiological cosmosis was lacking, and finally, in some cases there was non-union usually caused by distraction by heel plasters and flexion of the elbow and the sling. Radiological cosmosis was lacking. My method of management of humeral chat factors is rather different, and I learned the correct method from the bone setters. It does not matter whom you learn from, so long as what you learn is correct. My management of humeral chat fractures is rather different, and as Chandy repeatedly mentioned and emphasized, flexion of the elbow is a great deforming force. Elbows cast in extension, the fractures will unite. Orthopedic and trauma surgeons in the past have always been afraid of immobilizing the elbow in extension, as a stiff extended elbow is unfunctional and not compatible with the daily activities of living. However, this is an incorrect assumption. The textbooks have to be rewritten. I have personally conducted experimental studies by casting volunteers with no pathology from 4 to 6 weeks in extension cast and found that there was no elbow stiffness and that elbow movements returned to normal in less than a week or two. This study was conducted in the prison and is being written up in the archaic scientific manner that is required of medical publication business industry and shall be published in a reputed index journal soon. But for the purpose of this talk, it is enough for me to emphasize that immobilization of an elbow in an extended position for a fractured humerus with an uninjured elbow does not cause any stiffness of the joint. As far as the position of immobilization, proximal humeral fractures and middle humeral fractures are immobilized in full supination, while distal humerus can be immobilized or should be immobilized in mid-pronation. In both cases, elbow must be in full extension. The extension cast is continued for 3 to 4 weeks till the fracture becomes sticky and then is converted into an arm brace or cast till union. These type of splints by bone setters have given a bad name for non-operative treatment. The logic behind extension casting of humerus is extremely simple. In flexion, the biceps is contracted, the protective mechanism of triceps becomes loose, the bone is not biologically immobilized, it is prone to malalignment, and that is why biceps is called a disruptive muscle. It spans the humerus but does not attach to it. So, when you flex the elbow, a fractured humerus has to displace, whereas the moment you extend it, the fragments fall into place. Thus, all comminuted and long spiral oblique fractures of humerus due to the large surface heal really fast if you don't disturb the periosteal or medullary blood supply by reckless attempts to treat the X-ray and do a surgical intervention, either open or closed. Even transverse closed fractures seldom go for non-union, though their union time is longer. Triceps sleeve is an internal splint. Unless there is a very severe internal disruption, tearing both the triceps and periosteum, the principles that I have outlined will work, and that is the exact reason why I call triceps as sportive muscle. Here is a young girl with a shaft of humerus lifting her fractured arm instantly after applying an extension cast. You can see that she is in slight agony, but within 24 hours after giving a block, you can see that she has been able to lift the arm fully up, allowing telescoping of the fracture, which will give good union. And surprisingly for this girl, the fracture united in less than 3 weeks, and you can see the movements are in 4 weeks. In 6 weeks, she got complete movements, and this was the exuberance of callus in the cast, and this was the cast after removal in 4 or 5 weeks. Another case, rapid union, long oblique or spiral ones, through abundant callus and start union in 3 weeks, 4 weeks, and you can see the movements of the patient at the end of 4 weeks, and the flexion is full, extension is full. This disproves the theories that casting the elbow in extension will cause stiffness of the elbow. This is the final X-ray of the patient. This one is a very interesting series. Young doctor based in Mumbai had a fracture. 6 orthopedic surgeons wanted to plate her. With great difficulty, I could get a physiotherapist to put an extension cast and mobilize her. This young lady did not want a metal or scars, and I encouraged her to mobilize the shoulder from day 1. At the end of 21 days, everything was in line and position. It was converted to a short arm cast, and that is her in short arm cast. And this is about 4 weeks. At 4th week, this was changed to a Sarmento brace, and elbow movements were started. In 6 weeks, she got full elbow movements, and she sends me a message asking me if she can go to the gym, which I permitted. And then eventually from the gym, she sent me this video with full movements of shoulder, full movements of elbow, no scar, no disability. Now remember that in a metropolitan city like Mumbai, she is a daughter of a professor of medicine. She herself is a doctor, and she had consulted 6 orthopedic surgeons, and every single one of them wanted to operate on her. This means, in the interest of rapidly satisfying patient and in the interest of treating X-rays, we are operating humerus which would unite very well without surgery. The concept of extension casting may sound a little different from established current teaching and what is given in the books. I am probably one of the most blessed orthopedic surgeons in the world, because fortune gave me an opportunity to study fractures of humerus in great detail. For 15 years, I operated all shaft of humerus. And then for the next 13 years, I had to treat everyone conservatively because of situations. The days humerus fractures, these days humerus fractures are routinely fixed, and I was also fixing humerus chapters for many years before I understood the concept of biological fracture healing, which I learned during my stay in the prison. Fixation has a good chance of complications as shown before, but more importantly, conservatively fractures, they have less than 20% non-union rate if not done properly, which is inflection. 2 tricks you don't find in the book: 3 weeks immobilization in arm in extension, use a light cylindrical cast from from axilla to wrist in full extension, supination or pronation depending on the level of fracture as described in the previous slide. Use the lightest possible cast. I learned this due to necessity in prison. Smuggling one plaster bandage itself was a big job, so invariably I had to use a single roll of POP. After 3 or 4 weeks, when the fracture becomes sticky, the cast is changed to an arm gaiter extending from the axilla to elbow. Elbow mobilization is now started. By the time the elbow reaches mouth, the fracture is united, and the average duration is 8 to 12 weeks. And imagine, many internal fixations are protected with a slab for 6 to 8 weeks. Simple examples: fractures unite. They unite without an orthopedic surgeon entering the room. Displacement straightens when they are extended, and in less than 4 weeks we can convert them into arm gaiter and start full elbow movements. The patient moves the arm and hand full, raises above the head, and soon they are free from the plasters and gaiters. So, fractures which are displaced, moment an extension cast is put, they become replaced and realigned. More comminuted, more oblique fractures, faster the union. Fractures like this should never tempt a surgeon to put his knife, because they have to unite in 5 to 6 weeks if not operated, and extension will always straighten an angulated fracture, or if the fracture has overridden, gravity will ensure that the fracture is stretched, pulled and aligned perfectly. You can see, even initially when the callus is not very profuse, still little patience and the whole thing will form a callus. Biceps is a dangerous muscle that acts as a bowstring, and in flexion it will ensure that the elbow is always angulated. You can see the X-ray from the left that the moment we extend the elbow from a U cast to an extension cast, within 3 days gravity will align the humerus in correct position. You can be certain that an untraumatized elbow immobilized in full extension will never go stiff even up to 2 or 3 months of extension casting. They regain the elbow arc totally and fully within 2 to 15 days of plaster removal. It never takes more than 2 weeks for the elbow movement to come to full. Today, if I break my arm despite being an orthopedic surgeon, I will get treated only by extension casting and resume my surgeries and procedures on patients in less than 2 months. That is how confident I am. All the X-rays in this lecture are not from my patients. They belong to various patients treated in different parts of the world. The surgeons who have tried this method have been surprised and bewildered. This challenges our time honored learning that elbow has to be immobilized in flexion. That is apparently wrong, and bad results of conservative treatment, if any, happen to bad methods of conservative treatment. There might be a little shortening, there might be a little overriding, there might be a little angulation, but it is a non-weight bearing bone. Humerus has excellent blood supply, it is close to heart, and all fracture shafts of humerus always unite unless you strip the periosteum, ream the medulla, disturb the blood supply, or distract the fracture with heavy plasters. You can see the patients in OPD, how smiling and happy they are in the type of the plaster, and the number of patients now having been treated by this method cross about 100,000 all over the world. I will now tell you the steps of application of the extension cast. The immobilizer is removed. This has been done in a supine position. Nowadays I do it in a standing position. Sometimes when the patient stands and straightens his elbow, there is a chance of esophageal attack and he may fall. So that is why here I have done it in a lying down position. In a lying down position, one needs to give a slight traction. No C-arm is used. The fracture will get reduced automatically the next day. A stockinette is applied up to the armpit. The fracture is higher than middle, then we use an arm necklace as shown in the next patient, and then as the assistant gives the traction, the surgeon will apply the cast. If you are doing it in an operation theatre, you can check the same under C-arm to see that your traction has got the fractures in alignment, and then one single layer of fiber cast is applied. Once it is rolled and dry, we just turn the edges back so that they do not dig into the patient. The patient is made to sit immediately and encouraged to start swinging the arm so that the pendulum movements are started and wall crawling immediately. At this stage, we can also give alpha 1 and alpha 7 blocks, which will make the physiotherapy of the patient easy. In case we are applying an arm gaiter, what we do is we pass a stockinette over the arm and cover the deltoid. We can even tie it across the neck as a necklace, and again one single plaster roll is taken and an arm gaiter is applied. This patient had a comminuted fracture, was treated by a bone setter with an arm gaiter. Within less than 4 weeks, the fracture united fully. Segmental fractures take a long time with internal fixation, but with extension casting and arm gaiter in 6 weeks united. Eventually she regained full elbow and shoulder movements. So to ensure that the cast does not slip, we can add a necklace, which can be either by a stockinette or by a bandage, and after 4 weeks, 3 to 4 weeks, we convert to a Sarmento brace and the patient gets full function in less than 9 weeks. One can include an arm necklace to prevent slipping of the cast downwards. Initially, we did use slings after we converted extension to flexion, but now we realize that there is no need for a sling. We just let the patient free, and you have seen the pictures again and again. Does this method work? At the first reading, it might sound unorthodox, unscientific, and there was no supporting literature for this form of management. Most of my colleagues and friends asked, what will happen if I put an extension cast and my own colleague tells the patient that there is no published evidence and this is an experimental treatment or this is incorrect treatment based on bone setters? My attempts to get it published in scientific journals were also not initially successful, and I had to post my preliminary findings on social media and WhatsApp teaching groups which I run. And I started keeping meticulous records. In less than a year, I had over 100 examples of successfully treated cases with before and after results. Once I had 100 documented cases, then I decided, yes, the paper is worth publication. I sent it to one of the most prestigious journals in trauma, Acta Orthopedica Belgium, and they published it as an original study with the original X-rays and the entire details of the procedure. So now you do not need to worry about the harsh criticism from any colleague for using such unorthodox method. You now have a paper. Use this method in preference to nails and plates, and you may earn a little less, but the patient will bless you lifelong. Thank you very much for listening to this talk. You can connect at the above email address, or you can send me a WhatsApp message on 97910 This is a lesson, ongoing lesson in IAOS Biological Methods course for those who have already done the course. Thank you.
Hi, good morning everyone. Today I'll talk about featherweight plaster technique. It was developed by me just to apply as a very light plaster post-operatively and a routine also. The lightest plaster in 2018 are named as featherweight to make use of limbs early and available to the all corners at affordable cost. Nothing can replace plaster of Paris, as it is the only material free of allergy and beats up to 6 layers through up to skin. A lightweight but a strong plaster is utile as post-surgery slabs as well. It makes use of limb easy to use assisted ROM. Cement walls can be very lightweight when iron mesh reinforces it. Wait and think before plaster. Is there a vascular compromise, upper tibia, supracondylar or calcaneal fracture? Do you have a stable erection? If it is not under pressure, especially in supracondylar humerus, the spike and the plaster applied in flexion. Did you protect bony prominences? Did you apply ample cotton in fiber cast and settling plasters? Always apply slab with elastomer bandage. A 3D printer's costly light cast, the future, but only in hairline fractures. Routine plasters may be very heavy and cumbersome and may not serve the purpose. This heavy plaster did not reduce. Standard plaster up to 2 kg, while the featherweight plasters are mere 50 grams, allow work on same day. This person, he can hold the bottle same day, but the other person have to hang it into a arm pouch. I too tried to put a skeleton into plaster to make it stronger yet light. Different materials we tried to give a skeleton into plaster by aluminum strips, iron strips, wooden scales, plastic scales, X-ray film strips, cardboard box strips, newspaper and plastic core of the gypsum itself. Look at these plasters, so light a child uses a limb next day. Materials needed apart from gypsum bandages is cardboard strip used to skeleton from box of plaster bandage itself, antifungal powder clotrimazole as a booster, dental green powder to smear over the ipsona to make it waterproof and stronger, white paper as a lamination and a color from the X-ray film covers, stockinette, elastable bandage, flat plastic cores and adhesive pads on bony prominences. 3 months of plaster in this case turned skin cracked, smelly and black. And cracked itchy skin of the sole after plaster, its fungus growth on the skin. A 6 inches gypsona is 160 to 180 grams cut into 1 to 2 inches, 10 to 14 grams per strip. Say bye-bye to a smelly, macerated, cracked black skin coming out of the plaster. It is fungal, prevented easily by the single coat of clotrimazole. See, after 45 days of plaster, how clean skin comes out if clotrimazole was applied. A plaster powder dental green is for dental use jaw molds. It is a very strong saliva resistant and costs only 50 rupees per kg, and a very small is applied over the plaster after finishing. Paper comes with the patient non-digital X-ray film, so I use as a cover as a waterproofing also. Adhesive pads for the bony prominences. These are felt pads. You cut it or put it over the bony prominences. It is available with the name of Delta Terry Net 10. Cardboard strips are true skeleton, and Trichofix as a stockinette, and elastomers. These are very special bandages. They are very soft, a super non-constricting soft slab binder in place of cotton bandages. One of the key materials incorporated is flange, plastic core of the Gypsona bandage, flattened and placed over the cardboard. You have to roll it to make it flat.
Here we have
Other things
collecting
required for the plaster.
the ingredients for the featherweight plaster. We take yellow paper which covers the X-ray film, old X-ray films. We cut it into a strip and use as a lamination as well as cover and give good contrast. We take 6 inches Gypsona bandage, cut it into the 1 to 2 inches strips of 70 to 80 centimeter and roll it into bandages to make apply as per size. We collect it like this. Also, you have to keep ready the clotrimazole powder, which is to be applied on the skin before plaster so that the skin always comes fresh and there is no maceration. And we collect classic stone powder. This is dental stone powder. This is to be used over the Gypsona bandage mixture so that it makes the thing waterproof and 5 times stronger. For another reinforcement, we take a cardboard box. This is the box packing of plaster bandages, and we cut it into the thin strips and batten and apply as a sandwich over the plaster. That gives the real reinforcement to the plaster. And we cut cotton, and this is all ingredients we need to give a featherweight plaster.
This is the actual plaster, a simple case. Malunion, osteoclast, proximal block used, painless. This is a malunion. This is osteoclast is done, and there is no pain.
You see, the reduction is almost painless because the block has been given.
This proximal back is a perivestial, proximal to the bones. 1
I
ml.
put osteoclast without causing much pain. कितने कम दर्द में हो गया भाई साहब? Small amount of cotton is needed only on the ulnar prominence.
So I give cotton only on the ulnar head.
Of the plaster here, so I'll apply one layer first. This each piece weighing 14 gram.
Yes, each plaster piece is 14 gram.
And then
Then
I
take a
apply
cardboard,
this cardboard
reinforced with the
and the
plastic
plastic
strip.
strip. So that is the main strand. And then I apply and the bandage. So this is now second layer. And the third layer. And fourth layer. So now this is 55 grams of plaster, vitably as strong as a thick plaster. At last we have to apply the green
for the making waterproof and strong. This is the dental green smeared over the plaster. Then finally the paper and reinforced with the paper, so it makes waterproof and strong both. To give it the waterproofing and strength. And hold it for a minute and leave it strong. Plaster just completed. Being thin, hardens and dry quickly and allows working immediately. Slings we don't advocate unless pain or swelling asks for. This is cast index, simple radiological predictor of the plaster cast failure in pediatric distal forearm fractures. This is article by a very good journal. The cast index principle is known as Hillingdon cast index. I'll explain what it is. If you measure the AP and lateral, the cast index is a ratio of sagittal to the coronal width from the along inside of the edges of the cast to the fracture. A cast index of 0.7 was used as a standard in predicting fracture displacement. The cast index has previously been verified in experimental study. Creating a gutter, we press the fracture in between, so create a dimple or a dent that creates a vascular gutter. It allows sideways vascular flow, vascular drainage and guttered plaster. So it doesn't allow swelling to occur because it gives fluid escape effectively. Featherweight single bandage fiber cast pica 2 like 200 grams and hygienic, and patient can walk in this plaster even. Our patients enjoy the trauma time. Thank you very much. Use featherweight plaster always. Thanks. Hi everyone. Today something very interesting thing, that is clavicle fracture jet age begins by Dr. Arvind Divakar. So the name clavicle comes from Latin clavicula. Clavis means key due to its rotating action like a key. 5 motions are retraction, protraction, elevation, depression and posterior rotation. So it behaves like a key. And moreover, it acts as a lever also. Whenever there is an abduction of the scapula, it rotates posteriorly the clavicle, so rotating like key. New view for better anatomy. Straight AP view, you can see downward, that doesn't show anything, but a oblique view above, it shows the angulation of the clavicle. So this is how the X-ray is taken, and this is also known as cephalad view. You can see in the first X-ray, you can see fracture clavicle clearly displaced, but in routine X-ray, you don't see any fracture. So always learn whenever difficult thing, you have to take an oblique view. A shaft clavicle distal fragment carried by the weight of arm to the anterior. This is a CT scan of the actual patient, and you can see the fracture is being displaced anteriorly and downwards with the weight of shoulder and arm. So non-union, they define most clavicle fracture non-unions are symptomatic, not asymptomatic. That's what they say. Therefore, non-union should be considered a problem. And we cannot afford to have 1/5 having this problem. So they thought that non-union is 1 by 20%. But it's a wrong data. Showing non-union rates 20%. De facto, surgical patients more often go into non-union. And see how long they will see a non-united fracture.
कितने साल पहले टूटा था? 15 साल हो गए। इसमें प्लास्टर बना था कि नहीं बना था? एक बनी तो 2 बार बनी तो पट्टा बनी तो पट्टा बनी हुई है।
He said brace have been given some doctor.
अच्छा, और अब कोई तकलीफ नहीं है।
Of ergonomic treatment clavicle by Dr. Divakar that assures union even in wide separation or combination, hygienic, no malin or non-union, no pain after arrival to OPD, no sling as all function allowed on day 1, most return to work on day 1, makes 4 weeks fracture union time a pleasure than a curse, no bump at union side, no skin problem, no fall asthma, no messy feeling. Look at my new method first. All persons get pain relief in 5 minutes because of the portal blocks given immediately. No analysis. I don't give any medicine, neither calcium nor analysis. They are allowed to lift limb and do whatever they want. Ride back own bike is possible if they prefer it. Of course, all this gift with early union, no deformity, no work holiday, and no much cost. New pain relief methods are hexadilutin, 2% xylogen, 1 ml only at certain points gives analgesia by portal effect, lasting 1 week, allow motion at full. Alpha 6 is this trapezius, alpha 1 is here, and this is alpha 1A. So we prefer this, and third one is here on the acromion.
कितना टाइम हुआ फ्रैक्चर हुए? 7 दिन।
7 days,
और आपको इंजेक्शन लगा था, उसके कितनी देर में दर्द गायब हो गया था?
5 minutes में।
अभी भी गायब है? तुम पहले दिन से ही गाड़ी चला रहे हो? पहले दिन से ही गाड़ी चला रहे हो? कोई परेशानी नहीं है? अब भी कोई दर्द है?
Within 10 minutes of portal block, clavicle fracture man able to ride bike and allowed throughout union time, which is not affected, rather shortened. Slings never needed. Not only pain subside in minutes of fracture, clavicle and dislocation, most patients need only 3 injections, 1 week apart during the whole course of union in 4 weeks, and that too without sling. You heard right, without sling. Slings are deforming force, we reckon. With a full working allowed same day, even riding own bike back to the home. Many patients who get treatment at other places, later someone tips them to us, awed by our portal facts. And you know why this key motion of the clavicle? When you allow them to work, the key motion resets the clavicle in better place than with the sling alone. Malunion, it is they define. The problem seen in malunion, drooping of shoulder, shortened clavicle, malrotation, resulting in pain, shoulder function, and cosmetic unacceptable. You don't see all this with the new ergonomic method of clavicle. The treatment renders surgery as a fashion rather than need. Compromise of NV structure by the callus and the malunion. You can see the pressure over the first rib and vascular bundle causing pain and paresthesia. Certain lobby in favor of early fixation of all clavicle fractures. As some paper tells, clavicle never has bone union unless internally fixed. They have shown some CTs that only fibrous union is there in conservative methods. So they have applied these methods. Surgical treatment rarely indicated except in lateral 1/3 fracture, presence of neurovascular injury, non-union cases. So we agree in this. Surgery is a choice for highly anxious rich VIPs. Absolute indications are here I have shown. Bad scar apart from implant failure is common with the surgery. Bad scar is almost always there. Implant failure is in many cases. When surgery complicates, it's insoluble. Unlike the worst of the conservative may be asymptomatic. This is from Dr. Hasmukh. He has sent this case. This is 5 years operated, still non-union and pus oozing and bad scar. So this is taught wrongly. The figure of 8 bandages. This is applying bandages is mindlessly common by non-orthodox and bone setters. What it does, not only a mass, but a static tailor-made bracing cuts through the skin. You can see this cut because of overpressure. What brace I use is a very soft. So introduction of hexadiluted 2% xylogen entered recently discovered portal points in soft tissues quite distant to the injury of pain. But recently I have added a new method. We inject the proximal periosteum of the fracture. That also works as good. This is what a recent addition. This is my second book and this is in Italian translation by Dr. Mario. 4 months old conserved by stale method of district hospital. The old method, non-union problem, and the patient still comes to me. So the old conserved method is really bad.
कब हाथ लगा?
Particular brand, Mediate.
जब इंजेक्शन लगा तुरंत आराम पड़ गया था? उसके पहले क्या था?
उससे पहले दर्द था।
आप गाड़ी चला पा रहे हैं?
अब गाड़ी चला के मैं खुद
आए हैं। आपको कोई परेशानी नहीं है इसको बांधने के अलावा? इसको बांधने में भी दिक्कत नहीं है? मजा आ गया इस इलाज में?
This brand has been so far best. We prefer to wear over the clothes, not over the skin. Divakar's method, test xylogen on arrival, inject 1 ml hexadiluted xylogen first dorsal wave space, distal dorsal interosseous and trapezius alpha 6 and over the periosteum acromion alpha 6A. Send for the X-ray afterwards. When the pain is relieved, then I send for the X-ray. I prefer X-ray both clavicle to show patient gravity by comparing uninjured side. I apply fitting meek brace, select by trial, not by brands. This is a very, very highly displaced comminuted fracture. All the people told that it will not unite, and it was a trapezius impingement as well. But still the fracture is united with my method. Even the trapezius pierce was freed with the movement, and the bone united at last. You can see on day 85, fracture is very well united. astonishing pain relief. This patient has come from the bandage application after hospital.
बस मुड़क के आ जाओ, वापस आ जाओ, वापस आ जाओ।
Just only
कितना आराम हो
have
गया?
injection and immediately
20%।
ऐसा लग रहा है घर गाड़ी चला के चले जाओगे।
हाँ, पहुँच जाएंगे।
बहुत अच्छा लगा इंजेक्शन ही। आज तुम्हें टूटे कितने दिन हुए?
कल संध्या का टूटू।
अच्छा। तो भाई जिस दिन से इंजेक्शन लगा उस दिन से खूब काम कर रहे हैं। आज 20 दिन हो गए दवाई नहीं खाई तो भी आराम ना हो।
आराम।
हाथ उठाओ जरा बढ़िया। गुटखा बीड़ी तंबाकू बंद किया? तुम्हें इलाज अच्छा लगा ये? तुमने पहले सरकारी में कराया था उससे परेशान हो गए थे कि नहीं हो गए?
भाग गए थे वापस।
चलो ठीक है। क्लेविकल फ्रैक्चर 3 वीक्स। हाथ ऊपर उठाओ। अब कोई दर्द है इसमें?
this boy can undo shirt comfortably on day 7. No analysis needed in most. In spite of the old teaching of arm support by pouch, our methods prove that sling deserves dustbin only. Add ergonomics and the rotations of the clavicle not only unites faster but aligns the fracture as well.
हमको फ्रैक्चर था।
फिर इंजेक्शन कहाँ लगाया?
इंजेक्शन हाथ में नीचे लगाया।
कहाँ? यहाँ पर?
हाँ।
फिर उसके बाद दर्द कितनी देर में कम हो गया?
दर्द 15 से 20 मिनट बाद 40% कम हो गया।
टूटे कितना टाइम हो गया?
Saga continues. Hundreds of
कितने समय हो गया टूटे हुए? चोट लगे कितने दिन? 7 दिन हुए। तुम 7 दिन से बिल्कुल ठीक हो, कोई तकलीफ नहीं है, हाथ उठा पा रहे हो? उठाओ। हाँ कोई बात नहीं, जो दर्द नहीं ऊपर जहाँ टूटी वहाँ नहीं कर रहे, और वैसे कोई तकलीफ नहीं है तुम्हें, बढ़िया अच्छा रहा।
So my take home message, never be prisoner of fixed ideas. I always say ars longa vita brevis. Latin quote, life is short, arts are long. Be the gardener, not the carpenter. Thank you so much.